The art of conversation lies in listening. Malcolm Forbes. Hi, my name is Dr. Kritika Mehra, and welcome to the art of patient communication. The fact is that our patient communication can only be as good as your ability to listen. In my early years, when I was just practicing and just starting out, I went and did lots and lots of courses to be a better listener, to be a better communicator. And what I found that there was three things that were told to be a good listener. One was not to interrupt when somebody was talking to you. The second one was to repeat what they were saying to you, sometimes even word by word, to make sure that they understand that you listen to them. And the third one was to give facial expressions or by giving verbal cues like, mm-hmm, mm-hmm. What I realized that over the period of time when I was having the conversations with my patients, I was so stuck in making sure that I was doing those three things one by one that I was actually not taking any of what they were saying in and processing it properly. I was just too focusing on doing the or memorizing what they exactly said so I could repeat back to them, or not interrupting them at all, even though I had more questions to clarify what their complaint was or what their issue was. And this actually really proved it to me when I was on a phone call as a coachee with one of my fitness coaches over the phone. And here I am on the phone talking to her about the issues that I am facing, in my fitness journey. And on the other end, she's talking to me and she's going, hmm, 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 hmm. And I found that quite annoying actually, because it didn't even match with my pauses or my tone or my speed of what I was saying, or even the emotion in that moment. And then I realized that what she was actually doing was she was pretty much going through her checklist and was really focusing on the verbal cues, and she wasn't actually connecting to me. And the whole conversation setup felt extremely fake over the phone, and the whole relationship was very transactional. And what actually ended up happening was I ended up leaving her because it wasn't working. I didn't feel connected to her as much. The point that I'm trying to make is that better listening actually leads to better connection and better competence, because better listening gives you better understanding. Better understanding gives you better diagnosis and better treatment planning and a lot better relationship with your patient. In recent times, where the knowledge is available to most of us in abundance, I observe other people having conversations where most of the time they are actually trying to one up themselves. And exactly the same way, when the patient comes in, most of the times they actually know or they've Googled what's actually happening to them. So they may come in with a preemptive thought that that's what they are going through. And when they come in the chair, we, instead of us being the clinician, we start to say a lot without actually understanding the patient really well. And what happens is the patient ends up feeling very confused and overwhelmed. A good listener is actually not someone who is doing those three steps that I talked about at the start. A good listener is someone who actually lets the patient or the client unpack of what they are going through or what they are feeling and be a facilitator for that, because that will give us enough data to treatment plan them. Mark Goldston, a psychiatrist, he actually explained four types of listening, which kind of is correlated to four types of talking. And I will try to explain you all these four types of listening in a clinical setup. The first one is removed listening. So a removed listening happens when you're actually physically sitting in front of the patient, but not actually mentally with them. You're either sitting thinking about the patient before or the patient after or completely something else. And that can be quite an insulting type of listening because you're actually not giving the most important person in the room the attention they deserve. The second type of listening is reactive listening. This type of listening happens when the patient is actually talking at the clinician. So, for example, a patient has received a certain kind of treatment and now they have come back to you. And most of the times they will say to you, "Oh, it just doesn't feel right. It just doesn't feel right." That happens in dentistry. We would have done a filling for them, and then they come back next week or so, and they will be like, "It's just not right." And we can a lot of times take that comment personally and get quite defensive. And what happens in those scenarios is we actually get away from problem solving, and the whole situation becomes quite redundant, and it can even escalate to nothing. The third type of listening is responsible listening. Responsible listening is when the patient is actually talking to you, which is quite the way it should be. You are all ears listening to them. So I'll give you an example with the next type of listening so you can understand. And the fourth type of listening is receptive listening, which is the gold standard, which is when we are talking with each other and we are actually problem solving. Now, let's go back to the third listening, the responsible listening and receptive listening with the example. Now, in this, what happens is, for example, a patient comes to you with a pain 10 on 10, and they are saying they're in a lot of pain and they want you to help them. In this scenario, you have actually listened to them and come up with a diagnosis, you've treatment planned with them, and you've said to them, look, X, your problem is X, and this is the treatment you need. And I believe you need a specialist attention, and I'm going to organize a referral for you. And off they go on their way. Now, that problem solving is responsible listening, where you have actually sat with them, you've heard their problem, and given them a solution. Receptive listening is when you go that extra mile, where you think, okay, well, today is Friday. This lady is in pain 10 on 10. So the long term treatment is obviously referring her to a specialist. But what else I can think? I can think that today is Friday, tomorrow is weekend. The lady, may not be sleeping overnight. So maybe I can prescribe her some antibiotics or some pain relief. And even when I'm referring to the specialist, I am keeping in mind where they live, which city is closer to them, where the specialist is. So I'm actually thinking about a lot of things that are unsaid and problem solving for the patient. That is receptive listening. This is the type of listening where you want to be in so they feel heard and they feel felt. And when I am doing my conversations with my patients in the consultation room, I try to keep an acronym in my mind, not the three things at the start that we discussed, the verbal cues, not interrupting, or the repetition. Instead, I like to think of I see you. So the first one is I see you, which means I actually see you, I feel you, and I am going to treat you so you feel heard. That's the first scenario. That's always in the back of my mind. The second is I see you, as in the letters I see you. I means important, C means critical, and U means urgent. So important means that when I'm treatment planning from the clinical aspect, important means what needs to be treated in the next year, right? Critical means what needs to be treated in the next 6 months. Urgent means what needs to be treated right now. So that's the treatment planning that I'm doing when I'm keeping these things in mind. And the other thing is, again, listening the unsaid, is that what is the ICU, important, critical, or urgent, from patient's perspective? For you, urgent could be a molar on the top right hand side or any other problem in your field of profession. in my profession, for example, the urgent thing could be an upper right molar with a big abscess. But for the patient, the urgent could be the front tooth that is broken because that is socially keeping them conscious. So you have to find the blend between your ICU and the patient's ICU so you can treatment plan well. And that's when they feel heard. Let's give you a real life example of a patient that happened with me in my early years of dentistry. Let's name her Margaret. So, Margaret was not a very regular dental patient. And one day she came to us and she saw one of our senior dentists, and she had a complaint of a broken upper right molar. The main complaint was that her tongue was cutting into it because it was very sharp. On clinical examination, the dentist, he said, look, it's an old silver filling. It has some cracks in it, like it does, and we just need to replace it. And they just ended up replacing the filling for Margaret. After that, Margaret she went home. She was very happy with the treatment. And then 2 months later, she comes back and she says, oh, it just doesn't feel right. It just feels very different. And this time she was seeing another dentist in the same practice. And it was adjusted, thinking that it just had a high spot, which is a very common complication that happens after a filling. The filling was adjusted. Margaret was happy again. And off she went. The third time round, she was actually booked in with me. And it was probably after like a month or so of that adjustment. And she still had the same sort of an issue. She just came in the chair and she said, look, I'm just not happy. I don't understand. The filling's been done. Why does this tooth still feel so sharp? It's just cutting into my tongue all the time. And this time I said, look, let's just polish the filling off for you and then see how you go. And I polished the filling for Margaret, but she wasn't quite convinced as she was leaving. 2 months later, I see Margaret again, and thankfully, she was again booked in with me. This time, as I was walking out to get Margaret, I thought the complaint is the same as I can see on the appointment book, and I have read the notes because it's a good practice to do that before you go and get a patient again if they're coming in for a similar complaint again and again. So I was like, okay, I'm going to walk out and just have an open mind and see what's actually happening to Margaret. And Margaret comes in, same sort of a complaint. The tooth's really sharp. And she said, look, if we have to, let's just take this tooth out. And this time around, I first thought, you know what, I'm just going to check her all other teeth with my gloved fingers so I can feel how sharp the others are. And in that test, it was pretty much either the same or, if anything, a little bit smoother than the other teeth because it had been polished off twice now. Then I thought, let's just look at the tongue because it's the tongue the patient is complaining of repeatedly that it's cutting into the tooth. And so I'm so glad I did that because when I looked at her tongue, it looked some form of oral cancer. That's when I stopped and I said, look, Margaret, I think we need to escalate the situation and you need to see a specialist. So I went on, organized an appointment for her to be seen as soon as possible. And then patient was referred back to the specialist. And 2 months later, I actually got a card from the patient thanking me for listening to her attentively because what she had was squamous cell carcinoma, and she had a history of cancer somewhere else in her body, which was in remission, but it had come out this time in the form of oral cancer. And if that hadn't been diagnosed soon enough, she would have ended up losing her life. The bottom line of today's podcast is listening to the unsaid and really, really helping the patient unpack their important, critical, and urgent needs or their wants. Thank you for listening, and I hope you got something out of it. Follow me on Instagram and do not forget to subscribe to my channel on YouTube. See you next time. Bye.